Welcome back, Neurophiles. Dr. Ribbonick here. Today's topic is interpreting CT perfusion for the treatment of acute ischemic stroke. This talk is a bit long and complicated, but then perfusion is a complicated topic, so feel free to use chapter markers below, slow things down, speed things up, whatever helps you learn. This video is rated R for residents due to clinical uncertainty, complex language, and moderate quality of evidence. Medical students require accompanying resident or attending guardian. I have no relevant financial conflicts to disclose. As always, the cases presented in this talk were modified slightly for teaching purposes. CT perfusion is an exciting and rapidly evolving imaging modality, but for the purpose of this talk, we'll try to adhere closely to high-quality evidence. Debates about the finer points of perfusion are outside the scope of this video. Lastly, no single imaging modality can qualify a patient for stroke intervention. Let me say that again. No single imaging modality can qualify a patient for stroke intervention. You must always look at the entire clinical picture. Why do we need CT perfusion? Well, hopefully that will become clear in the first section. We will then discuss the fundamental hemodynamic properties, review well-validated clinical uses of CT perfusion, discuss some caveats and limitations, and conclude with some additional uses of this imaging tool and a tidy algorithm to bring it all together. For decades, we have used the non-contrast head CT and CT angiogram to select patients for perfusion therapy. Why then do we need CT perfusion all of a sudden? In 2015, multiple high-quality trials established thrombectomy as the new standard treatment for acute ischemic stroke caused by a large vessel occlusion. These trials evaluated endovascular therapy within the standard window, 0 to 6 hours from stroke onset. Hermes collaboration pulled data from these major trials and analyzed how time from symptom onset to start of intervention affects clinical outcome. The longer it takes to intervene on a patient with a large vessel occlusion, the lower the chance of favorable outcome. And by about 7 hours from stroke onset, the benefit of endovascular therapy disappears. There's no getting around it. Time is still brain. Time still matters when it comes to acute stroke interventions. But there are some patients that can still benefit from intervention beyond the conventional time windows. Hypothetical scenario. Say you have 3 patients with left middle cerebral artery occlusion. At the time of occlusion, the supplied brain is hypoperfused, and the entire territory is penumbra. Without blood flow, this hypoperfused brain shifts to permanent infarction over time. At 6 hours from occlusion, in the first patient, the entire MCA territory may have progressed to ischemic core. In the second patient, only half the MCA territory progresses to irreversible ischemia. And the third patient is doing quite well with a very small ischemic core. By 12 hours from onset of occlusion, patient 2 may look like patient 1 with a completed MCA stroke. But even at 24 hours, the third patient may still have much viable brain. This is the patient that may still benefit from perfusion. By the way, the rate of stroke progression to ischemic core is highly variable and depends on initial stroke size, collaterals, and age of the patient, and other factors. Let's make this example more concrete. A 46-year-old man with multiple vascular risk factors presents with a left MCA occlusion. Time from last known well is 1.5 hours. His deficits are quite disabling. Right hemiparesis, left gaze deviation, right field cut, significant aphasia, what you would expect for a left MCA syndrome. An 8-stroke scale score is 14. Hermes data tells us that within the standard thrombectomy window, 6 hours from stroke onset, chances are there's a significant amount of viable brain, and we can use the good old non-contrast head CT to select patients for intervention. To assess ischemic core systematically, let's apply the aspects, which stands for Alberta Stroke Program Early CT Score. This scale divides the MCA territory into 10 segments: head of caudate, internal capsule, lentiform nucleus, insula, and the 6 cortical segments. A point is subtracted for each segment that is hypodense. For example, a patient with a completed deep MCA stroke would lose 4 points. And the hypodensity in the cortical MCA territory could subtract up to another 6 points. What is this patient's score? Yep, this is a normal head CT, so the aspect score is 10. Okay, what if we change the timing? Now we have a 67-year-old man with multiple vascular risk factors who presents with a left MCA occlusion just like in the last case. But this time, patient woke up with deficits. Time from last known well is 11 hours. He has a full MCA syndrome and NIH stroke scale score is 20. What is the aspects in this case? I'll give you a minute. If you find it difficult to call, you're not the only one. If you find it obvious, don't get too excited patting yourself on the back. I adjusted the contrast for the purpose of this video so that the hypodensity projects better. And there is a hypodensity in the left head of caudate, internal capsule, and the lentiform nucleus. So I would say the aspect is 7. We certainly had to work hard to calculate it. I think we can all agree that it's difficult to define ischemic core on a non-contrast head CT. Low aspects supposedly correlates with a large core infarction, but it's not even clear how well low aspects predicts poor outcome. For example, in the large multicenter retrospective stroke thrombectomy and aneurysm registry, STAR registry, which was comprised of over 2,000 patients with internal carotid or M1 occlusion presenting in the extended window, patients with aspect score of 2 to 5, that's up to 80% of the MCE territory supposedly damaged, had 4 times higher chance of functional independence at 90 days if they received mechanical thrombectomy. What? Come on, I know it's a retrospective cohort, but good outcome with low aspects? Clearly we need a more reliable imaging modality to select patients for interventions. MRI is obviously the gold standard. Diffusion-weighted imaging, or DWI, abnormalities reflect actual histological changes that occur as a consequence of cerebral ischemia. But MRI is slow and cumbersome. Try getting a disoriented patient with a large vessel occlusion to stay still for 30 minutes inside the MRI machine. I'm being facetious. Most major stroke centers do have protocols to get MRI quicker, but CT perfusion is still more prevalent and only takes a few minutes. This is a CT perfusion for the patient we just discussed. An automated algorithm calculates and color codes the ischemic core and penumbra. I bet I don't even have to explain the numbers at the bottom of this page for you to guess that the core is in pink and penumbra is in green. And there's a huge mismatch between the two. Got it? Awesome! The talk is over. See you later. No. That's not how we work around here. Of course we're going to explain it. Let's dive in and briefly review the fundamentals first. The mismatch map you just saw is generated from the source images. These are called image columns. The first column are baseline CT images, followed by 4 useful parameters. Cerebral blood volume is defined as the volume of blood flowing in 100 grams of brain tissue. It's an indirect measure of collateralization and autoregulation, the amount of blood that can be delivered to brain tissue. Mean transit time is the average time it takes for blood to travel from intracranial arteries to veins across a capillary bed. 4 to 5 seconds is considered normal. Cerebral blood flow is the cerebral blood volume in 100 grams of brain tissue per minute. Cerebral blood flow is essentially cerebral blood volume divided by the mean transit time, the time it takes to deliver that volume. Cerebral blood flow predicts the core infarction, and does so better than the cerebral blood volume. Notice that CBV and CBF are preceded by a letter R for relative. CT perfusion does not actually measure the absolute volume or flow. Instead, blood flow and blood volume are expressed as a percentage of a presumed healthy brain tissue. So in each patient, an ischemic lesion in one hemisphere may be compared to healthy tissue in the opposite hemisphere. The last parameter, time to maximum, or Tmax, represents the time from the start of the scan until the maximum intensity of contrast bolus arrives into the brain. Delay in Tmax correlates with penumbra. For those of you who enjoy graphs, if you plot the density or brightness of injected contrast bolus versus time, you'll get a graph like this. Tmax is the time point at which the contrast peaks intracranially. Mean transit time is the average time that the contrast spends inside the intracranial blood vessels. Cerebral blood volume is the area under the curve. And cerebral blood flow is related to how quickly that blood volume gets to the brain tissue. The slope of the upstroke. In a patient with early large vessel occlusion, arrival of the blood to the brain tissue is delayed. Blood flow takes the side streets or collaterals instead of the main highway. But neurons are still ultimately getting the same blood volume, at least until ischemia sets in. Since cerebral blood flow is cerebral blood volume divided by mean transit time, when mean transit time increases, cerebral blood flow decreases. Again, CT perfusion doesn't actually measure absolute blood flow or ischemic changes like MRI does. We use CTP abnormalities as a surrogate marker of tissue hypoperfusion. This will become important when we talk about CTP's pitfalls and limitations. Back to the image columns. Note the color scale. Lower values are in blue, intermediate values are in green-yellow, and high values are in red. Let's take a look at our patient with left MCA occlusion. Which parameter is most obviously abnormal? Yes, Tmax is clearly delayed. Colors are more yellow-red. Tmax is great at identifying penumbra because it reveals high contrast between areas of delay and normal tissue. Tmax does not vary with tissue type like cerebral blood volume does. Gray and white matter receive different blood volumes. And this uniformity produces flat contrast in normal brain. So even small or subtle areas of Tmax delay are highly visible. Mean transit time is also increased, as expected. The decrease in cerebral blood volume in the subcortical left MCA territory, the bluer colors on the patient's left, represents infarcted tissue. And since cerebral blood flow is cerebral blood volume divided by mean transit time, cerebral blood flow is also decreased. Interpreting these perfusion maps is like reading your fortune in tea leaves. I get it. So for more consistent and objective results, these perfusion maps are usually subjected to some form of thresholding. We don't want to see everything all at once, just the important bits. And that's how we end up with this final image. On the left is the volume of a region with cerebral blood flow less than 30% of patients normal. CBF less than 30% cutoff is widely validated in clinical trials. On the right is an area of Tmax with a delay more than 6 seconds. This metric provides a reasonable estimate of final infarction in patients without reperfusion. So Tmax is used as a surrogate for penumbra. Subtract this patient's volume of ischemic core, 13 ml, from the volume of penumbra, 110 ml, and we arrive at the final mismatch volume of 97 ml. The difference between ischemic core and penumbra can also be represented as a ratio. In other words, our patient has 8.5 times more penumbra than core. Let's see how this works in clinical practice. Our clinically relevant cutoffs for stroke intervention come from 3 landmark trials: DEFUSE 3, EXTEND, and DAWN. DEFUSE 3 showed that patients with an ischemic core of at most 70 cc's, about 1/3 to 1/2 of MCA territory, and a potentially salvageable penumbra of at least 1.8 times that of the core, have better outcome with thrombectomy. The difference between core and penumbra was also expressed as an absolute volume of potentially reversible ischemia of at least 15 cc's. EXTEND trial extended the window for intravenous TPA to 9 hours. That trial selected patients with similar core size as DEFUSE 3, but allowed a smaller core to penumbra mismatch of at least 1.2 times, or at least 10 cc absolute difference. By the way, large vessel occlusion was not required in the EXTEND trial, but by definitions, you can see that some patients that meet DEFUSE 3 criteria may also meet the EXTEND criteria. The DAWN trial had the most complicated inclusion criteria. Since size of the completed stroke is arguably one of the most important predictors of clinical outcome, that trial focused on selecting a group of patients with smaller ischemic cores and large clinical deficits. Did you catch that? There was no penumbral requirement. As long as patients had small core infarctions, clinical deficits were used as a surrogate for potentially reversible ischemia. For the very elderly patients, over the age of 80, intervention was offered to patients with a small core, at most 20 cc's, and moderate to severe clinical deficits, an 8-stroke scale score of at least 10. For patients under 80 years of age, a core of at most 30 cc's was allowed with moderate deficits, an 8-stroke scale score of 10 to 19, and a core of up to 50 cc's was allowed if the deficits were severe, an 8-stroke scale score of at least 20. In the DEFUSE 3 trial, patients who received thrombectomy presented with a proximal large vessel occlusion within 6 to 16 hours from last known well. Median age was 70, give or take 11 years. Deficits were severe, with median and 8-stroke scale score of 16. Most, about 2/3, had unwitnessed stroke onset, usually awakening with stroke symptoms. While MRI was allowed for patient selection, majority of the patients were selected by CT perfusion. Median ischemic core was 9 cc's, far less than the maximum of 70 cc's. And median penumbra was 115 cc's, with a mismatch of over 10 times, again far exceeding the pre-specified ratio of 1.8. DEFUSE 3 was terminated early, for efficacy, after only 182 patients were enrolled. DAWN trial also offered thrombectomy to patients with a proximal large vessel occlusion, but this time presenting within 6 to 24 hours from last known well. Median age and deficit severity were similar to the DEFUSE 3 population. Vast majority of patients in the DAWN trial had unwitnessed stroke onset. Just like in DEFUSE 3, most patients were selected by CT perfusion. And the median ischemic core was small, 8 cc's. EXTEND focused on intravenous TPA, enlarging the window from 4.5 hours to 9 hours after last known well. By the way, if patients woke up with stroke symptoms, the onset of stroke was defined to be the midpoint of sleep. So technically, if a patient went to sleep at 11 p.m. and woke up at 9 a.m. with stroke symptoms, as far as the EXTEND trial is concerned, stroke onset would be 5 hours ago. EXTEND patient population was aged similarly to DEFUSE 3 and DAWN populations, but had milder strokes, median and 8-stroke scale score of 12. Majority of strokes were unwitnessed, most patients were selected by CT perfusion, and ischemic cores were small. Median penumbra was 74 cc's, with a mismatch of nearly 15 times, far exceeding the pre-specified ratio of 1.2. Also, large vessel occlusion was not a requirement, but nearly 70% of patients ended up having occlusions. Okay, take one last look at the criteria because we're about to apply them to real cases. Let's get back to the patient with whom I started the discussion of CT perfusion. As a reminder, he's a 67-year-old man with multiple vascular risk factors who presented within 11 hours from last known well, with global aphasia, right hemianopia, left gaze deviation, and right hemiparesis. An 8-stroke scale score was 20. Left M1 occlusion was confirmed with CTA. Would you offer thrombectomy? Let's apply DEFUSE 3 criteria. Ischemic core is only 13 cc's, which is less than the pre-specified 70 cc's, and the core to penumbra mismatch is 8.5 times, which is certainly higher than the pre-specified 1.8 times. So yes, this patient is likely to benefit from thrombectomy. Here's another case, a 74-year-old man with atrial fibrillation but off anticoagulation. He presented 7 hours from the midpoint of sleep, 11 hours from last known well. Right A2 was occluded. He has left sensory motor deficits, paucity of speech, and dysarthria. An 8-stroke scale score is 11. Would you offer any reperfusion therapy in this case? We can apply EXTEND criteria here. mismatch is more than 1.2 times, and the ischemic core is less than 70 cc. So intravenous TPA may be considered. Technically, DEFUSE 3 criteria would apply here as well, but the lesion is too distal for thrombectomy, at least according to our current evidence. Okay, what about this patient? 94-year-old woman with atrial fibrillation who presented 12 hours from last known well with acute left M1 occlusion, causing encephalopathy, left gaze deviation, right hemiparesis, right field cut, and global aphasia. NH stroke scale score is 18. To intervene or not to intervene? Let's apply DEFUSE 3 criteria. The mismatch is favorable, more than 1.8 times, but the ischemic core is over 70 cc's. So the risk-benefit profile for a thrombectomy in this patient is likely unfavorable. And the last example. 48-year-old man with dyslipidemia presents 6.5 hours from last known well. He went to sleep and awakened with severe deficits, including disorientation, right gaze preference, left sensory motor deficits, dysarthria, and neglect. NH stroke scale score is 19. Right M1 occlusion was confirmed. Here's his perfusion imaging. Would you recommend thrombectomy for this patient? Of course! DEFUSE 3 criteria are satisfied here. Patient is within 6 to 16 hours from last known well. There is a large vessel occlusion. Ischemic core is 24 cc's, which is less than 70, and penumbra is 4 times higher than the core. So this patient should get thrombectomy. Oh, and speaking of penumbra, can we predict if this penumbra is about to convert to ischemic core? What are the chances of this infarct growing? For that, we need to discuss different Tmax thresholds. Tmax of more than 6 seconds in green is how we typically define penumbra. Tmax of more than 10 seconds in red estimates the tissue at immediate risk of infarction. Dividing the volumes defined by these two delay thresholds gives you the hypoperfusion index, also known as hypoperfusion intensity ratio, or HIR. Hypoperfusion index of over 0.34 in the DEFUSE 3 cohort predicted poor collateral flow and significant infarct growth early over the first 24 hours. In this patient, we expect the ischemic core to grow rapidly without treatment. By contrast, the 4 to 6 second delays are mild enough that the tissue is unlikely to infarct. By the way, in a nice bit of synergy, the colors on this multi-threshold map correspond to the colors on the original image columns without any thresholds applied. So, riddle me this. Based on these Tmax multi-threshold maps, which of the two patients with left MC occlusion is more likely to experience ischemic core growth? Yes, the patient on the right. Sadly, he completed his left MC infarction and needed decompressive hemicraniectomy to treat malignant cerebral edema. I hope by now that you've realized that CT perfusion is incredibly useful, but just like any tool, it's not without limits. We determine candidacy for intervention based on estimation of ischemic core and penumbra. But what if those estimations are inaccurate? Are there situations where CTP can lead us astray? By the tone of my question, the answer, of course, is yes. Well, let's take ischemic core, for example. Cerebral blood flow measurement may under or overestimate the ischemic core. Let's talk about underestimating the core first. Remember that CTP maps do not actually identify infarcted tissue. They identify regions with low blood flow that can predict infarcted tissue. But cerebral blood flow in the patient with large vessel occlusion can change with time. Imagine a hypothetical patient with acute left middle cerebral artery occlusion. Cerebral blood flow is illustrated here as a function of time. Here's the well-accepted CBF less than 30% threshold. At 2 hours after stroke onset, cerebral blood flow drops significantly, below 30% of normal. Non-contrast head CT is still normal, and CBF maps register a core infarction, in pink. As expected, Tmax map shows a sizable penumbra. By 8 hours, a hypodensity may now be visible on CT, corresponding to a larger core infarction on the CBF map. But at the extreme of the 24-hour window, leptomeningeal collaterals may have already been recruited, and cerebral blood flow may improve a bit, just above the 30% threshold. So core infarction disappears from the CBF map, while Tmax shows a significantly delayed flow in the left MCA territory. This is a situation where collaterals came in too little too late. It doesn't matter that the blood flow is better, the tissue is already irreversibly injured. In this case, only the non-contrast head CT, or diffusion-weighted imaging MRI, can show you the true ischemic core. Practically, this discussion is relevant for two reasons. First, in a patient with unknown time of stroke onset, CT perfusion must be interpreted together with non-contrast head CT and clinical history. Some software packages make this easier by overlaying the CT hypodensity on the CBF map. Here, an area in blue is a hypodensity threshold of 5 to 12 Hounsfield's units, which is typical of acute infarcts. Some people even advocate relying on the gold standard MRI instead of the non-contrast head CT or CT perfusion, the closer you get to the extreme of that 24-hour window. The other practical point is that CT perfusion maps are very time-dependent. They only reflect the hemodynamics at the moment the scan was done. So if the CTP is performed at a primary stroke center and the patient is transferred to a thrombectomy-capable center, by the time that patient arrives, the initial CTP may no longer be valid, especially if there's significant transfer delay. So you might have to repeat the imaging. A similar situation of underestimating core also occurs after thrombectomy. Cerebral blood flow improves, and the ischemic core disappears from the CT perfusion because there's now blood flow in the irreversibly injured region. But in this case, penumbra also disappears, so you know you've made progress at improving blood flow delays. So core may be underestimated when ischemic tissue is reperfused by thrombectomy or after leptomeningeal collaterals are recruited. Overestimation of the core is arguably a bigger problem, because large core may exclude a patient from intervention. When a large vessel occludes, cerebral blood flow in that vessel's territory dips below 30% of normal fairly quickly. But hypoperfusion does not necessarily translate to tissue ischemia. Not if it doesn't last for long. If a patient presents early enough after stroke onset and reperfusion is quickly accomplished, the core seen on CTP would disappear. This is especially true of patients presenting within the golden hour. But you'll say, Dr. Ribinik, in DAWN and DEFUSE 3 trials, CTP was performed at or beyond 6 hours from last known well, so none of the patients were scanned within the golden hour, weren't they? Well, patients with unknown stroke onset were allowed in those trials. Let's say a patient presents with symptoms on awakening, last known well was at bedtime 9 hours ago. That patient comes to the emergency department and gets the following scan. Large core, large penumbra, no mismatch. Patient is not a candidate for intervention, right? But what if it's a situation like this? Severe hypoperfusion, but no ischemia. The non-contrast head CT provides a clue. Head CT is normal, suggesting that the patient may be within the early time window. This patient underwent thrombectomy for occlusion of the right internal carotid artery terminus, and contrary to the CTP, a follow-up CT on day 3 showed no large completed infarction. The ischemic core in this case was overestimated, so-called ghost core. It didn't really exist. The shorter the time between symptom onset to imaging, and from imaging to reperfusion, the higher the probability of ischemic core overestimation. Thankfully, situations like this are rare, 1 in 6 patients in a retrospective cohort. If you think you're dealing with a patient within this very early time window, you may consider a more stringent CBF threshold of less than 20%. The difference in volume between the less than 20% and the accepted less than 30% cerebral blood flow threshold could be quite substantial. Look at this example. The ischemic core by the accepted criteria is 44 cc's. Now, if this patient is over 80 years of age, they might be excluded from intervention based on the DAWN criteria, but applying the more stringent threshold for ischemic core removes the core completely and may allow us to intervene. So let's review. CBF may overestimate the core if CT perfusion is performed too early with respect to stroke onset. CBF may underestimate the core if CT perfusion is performed late with respect to stroke onset or after reperfusion. Okay, now let's discuss overestimating penumbra. It's 4 a.m., and you respond to a code stroke in the cardiothoracic ICU. A code was called for a 63-year-old man with multiple vascular risk factors, including atrial fibrillation. He was off anticoagulation for a coronary artery bypass grafting surgery, which he underwent earlier today without any complications. When sedation was weaned, the nurse noted significant expressive aphasia, mild right hemiparesis, and dysarthria. NIH stroke scale score is 7. He was last known well 11 hours ago, pre-op. Non-contrast head CT, CTA, and CT perfusion is performed. Head CT was normal. What is your interpretation of this perfusion study? There are no areas of ischemic core, CBF less than 30%. Tmax is delayed beyond 6 seconds in the left ACA and MCA territories. Total mismatch is 115 cc's. Seems to me that's a perfect patient for intervention. But the CTA of the head shows preserved intracranial flow. There is some asymmetry between the two sides, but nothing's occluded. What's going on? To the source images! Tmax is definitely increased in the left hemisphere. Mean transit time is barely increased. And cerebral blood flow and cerebral blood volume are essentially symmetric between the two hemispheres. Have you figured it out? Tmax, the maximum amount of time required for contrast to reach the brain tissue, is sensitive to delay in flow. For example, if the internal carotid artery is chronically severely stenosed or occluded, Tmax will be increased. But a chronically occluded carotid is generally a well-compensated state. Mean transit time may be mildly increased or normal. More importantly, cerebral blood volume will be normal. That hemisphere is getting enough blood, even though it's delayed, probably because it's arriving through collaterals. Don't believe me? Well, thankfully, perfusion software packages also provide multiple threshold maps for cerebral blood volume. In this patient, no matter what threshold is applied, cerebral blood volume seems to be preserved. CBV measures the relative volume of tissue that is vascularized, as compared to the unaffected side. This parameter generally does not care how long it would take for that tissue to receive that blood flow, as long as that blood flow eventually arrives. High CBV is a predictor of good collaterals, and low CBV can be a predictor of infarct core. By the way, as I said previously, CBF seems to perform better at estimating core, and that's why we rely on CBF instead of CBV. So, cerebral blood volume is not time-dependent. Tmax is time-dependent. If source maps show delayed Tmax with preserved CBV, you're probably dealing with a chronic carotid high-grade stenosis or occlusion that's well compensated by collaterals. It is in this situation Tmax may overestimate the penumbra. That's what this patient had. The lesion was emergently stented because of patient's severe disabling deficits. In the interest of full disclosure, I should mention that this is individualized medicine. There's no high-quality evidence for something like this, and certainly not everyone with such pathology should be acutely stented. Case in point, here's another example. 62-year-old man with multiple vascular risk factors who noted slurred speech during breakfast, the first time he spoke after awakening. Last known well was 13 hours ago. He exhibits dysarthria, mild left facial droop, and left arm drift. NIH stroke scale score is 3. CTA during the stroke code showed complete occlusion of the right cervical ICA, but intracranial flow was preserved. Interpret the CTP for me. Right, there's a small ischemic core in the right hemisphere. Once again, penumbra is large, 152 mLs, and there's significant mismatch of nearly 14 times. But now you know better than to fall for this. You are probably saying, show me the source images. Okay, Tmax is significantly delayed, no surprise there. There's even some delay in the mean transit time. But cerebral blood volume once again looks symmetric between the two hemispheres. CBV does not appear to be decreased enough to meet any of the accepted thresholds. Because of mild deficits, no intervention was pursued. This patient was treated medically with blood pressure augmentation. Patient's deficits improved, and on repeat CT perfusion, the area of penumbra has decreased from 152 mL to only 32 mL. Let's review. Again. CBF may overestimate the core if CT perfusion is performed too early with respect to stroke onset. CBF may underestimate the core if CT perfusion is performed late with respect to stroke onset, or after reperfusion. Tmax is time delay dependent and may overestimate the penumbra in patients with chronic high-grade stenosis or occlusion of the cervical carotid. The discussion we've been having until this point assumed a good quality study. Sometimes you get images that do not make any sense. Then how do we determine that the study is technically adequate? In order to generate the perfusion maps, the software needs to identify blood going into and out of the brain by way of normal vessels. In this study, the algorithm selected right MCA as its arterial input function and straight sinus as its venous output function. Change in brightness is plotted versus time as the contrast bolus flows through the artery and then exits the brain through the venous sinus. In a technically adequate study, the arterial input function needs to be bright enough and usually exceeds a hyperdensity of 150 Hounsfield units. The software also keeps track of side-to-side and rotational movement and generates plots for both in 3 dimensions. So, very little movement is present, artery and vein are properly selected, arterial input function is appropriately bright. This is a technically adequate study. Now, this image is technically inadequate, and that's an understatement. Patient moved and rolled during the scan, rendering arterial input function inadequate. So that's movement, but issues with proper selection of vessels show up from time to time as well. Here, the algorithm focused on bone instead of an artery. Thankfully, the image can be reprocessed with correct vessel selection. And finally, the most common locations where penumbral measurement is overcalled are at the base of the skull and the orbits. Here, even minor motion and partial volume bone create this artifactual, quote-unquote, delayed Tmax. Remember that the algorithm includes these areas when calculating the total volume of impaired perfusion. So while these artifacts are easy to spot, they're actually pretty difficult to subtract from the final volumes. Okay, those were the basics. Modern automated CT perfusion algorithms were designed for practicality, but you can always extract more information when you know where to look. The best evidence for the use of CT perfusion in the treatment of acute ischemic stroke exists for large vessel occlusion. But what about medium vessel occlusions? 62-year-old man with heart failure felt a shock of a defibrillator and collapsed without losing consciousness. He arrived to the emergency department within the golden hour, 50 minutes from symptom onset. He was noted to have left sensory motor deficits and mild left neglect, an H-stroke scale score of 5. Here's his CTA of the head, axial maximal intensity projection. Is there a large vessel occlusion? Here's the coronal maximal intensity projection. Challenging, isn't it? CT perfusion was also done. The territory of Tmax over 6 seconds matches inferior right M2 division, and there's substantial mismatch. Reconstructing the CTA in the sagittal view finally allowed us to visualize the right M2 occlusion. This patient was treated with IV TPA at an outside hospital, and by the time he arrived at a comprehensive stroke center, his deficits improved nearly to baseline and thrombectomy was not offered. But the point here is that CT perfusion helped identify the medium vessel occlusion. Even in experienced stroke centers, 1 in 3 distal vessel occlusions are missed with CTA alone. And interpretation of CTA is time-consuming. I mean, how many CTA reconstructions did we just have to review to catch that one medium vessel occlusion? Retrospective series suggest that adding Tmax helped catch virtually all of them. And as a bonus, when CT perfusion was available in these cases, CTA was cleared faster and with more confidence. So, CTP may help identify medium vessel occlusions. But what about posterior circulation strokes? Crash course on posterior circulation stroke. Majority of patients present with non-specific symptoms like dizziness, dysarthria, encephalopathy. Less than 5% have the signs with the highest predictive value, like Horner's, cross-sensory deficits, quadrantanopia, oculomotor palsy, and motor deficits. So imaging becomes key in the diagnosis. Non-contrast head CT misses over 2/3 of acute posterior circulation strokes. Did you hear that, my future emergency medicine colleagues? I have very little confidence in the non-contrast head CT in these situations. Adding CTA roughly doubles the sensitivity. Incidentally, the sensitivity is similar to relying on CT perfusion alone, but that's not the standard practice. Also, you have to be careful of those base of the skull artifacts on CTP. A combination of CT, CTA, and CTP can help diagnose 9 out of 10 patients with posterior circulation stroke. Well, now we're talking! Consider this case. 86-year-old woman with atrial fibrillation and apixaban, as well as other vascular risk factors, who developed new vertigo, nausea, vomiting, and dysarthria, largely nonspecific symptoms. Reportedly, she felt unwell for several days, but symptoms worsened within the past 2 hours. On arrival to the emergency department, her NIH stroke scale score was 2 for mild ataxia. That's not particularly surprising since NIH stroke scale is really designed to quantify anterior circulation lesions. CTA was obtained. Basilar artery is severely stenosed at the origin, and both terminal vertebral arteries are practically non-existent. Here's the sagittal view. Incidentally, symptomatic large vessel atherosclerotic disease, like in this patient, is a common cause of posterior circulation infarction. So our patient has terrible-looking vessels. NIH stroke scale score is 2. Is this a stable or unstable situation? Do we expect her to deteriorate despite medical therapy? Well, what about her CT perfusion? Her CT perfusion showed significant areas of Tmax over 6 seconds. And as expected, she deteriorated within 48 hours, developing lethargy, bilateral leg and arm weakness. And at that point, she underwent emergent mechanical thrombectomy and angioplasty. The vessels were so tortuous that a stent could not be placed. You may have noticed that there are no areas of ischemic core, CBF less than 30. Don't rely on the automatic CBF calculation in posterior circulation patients because it performs poorly. CBF less than 30% threshold was really validated for anterior circulation strokes. Post-intervention, there was still residual stenosis in the basilar, but at least the V4 segments of the vertebral arteries were open. Be wary of applying CT perfusion to posterior circulation strokes. Why? Well, mainly for 3 reasons. First, these patients were excluded from DAWN and DEFUSE trials, and perfusion criteria for intervention in the posterior circulation are not well defined. In fact, there is paucity of high-quality evidence that intervention is even effective. It's a rare disease, often with poor outcomes without intervention, so experts are generally in favor of intervening in symptomatic patients rather than enrolling them into trials. Second, specificity suffers because of those pesky skull-base artifacts. Here's what I mean. CT perfusion erroneously diagnosed perfusion abnormalities in the posterior circulation in this patient with a right basal ganglia stroke. And the third reason is a technical one. Not every CT scanner can do whole brain or volume perfusion. Some only acquire 2 axial slabs that correspond to anterior circulation territories, a protocol that's designed to fulfill the DAWN and DEFUSE criteria. You may have to specifically request the CT tech to lower the slabs if you want to image the posterior circulation in that type of scanner. Posterior circulation stroke is one example where the clinical picture may be confusing. Stroke mimics, like encephalopathy, seizures, hypoglycemia, are another challenge. Can we use CT perfusion to assess for stroke mimics? Maybe. Here's our last example. 63-year-old man with multiple vascular risk factors and history of remote renal transplant, immunosuppression, and intracranial nocardia abscess, which was drained in 2020 through a right craniotomy. He suddenly developed acute left hemiplegia, right gaze deviation, and left hemianopia. An H-stroke scale score is 13. Sounds like a right MCA syndrome, doesn't it? Symptom onset was witnessed by the nurse. No problem, let's call a stroke code. Non-contrast head CT was normal. On the CTA, right middle cerebral artery and right cervical carotid artery are open? What? Let's run CT perfusion? No core, no penumbra, no mismatch. CT perfusion doesn't seem to be of much help here. Let's look at the source images, just in case. Do you see it? Tmax is symmetric, MTT is symmetric, but cerebral blood volume and cerebral blood flow is increased in the right hemisphere. Hyperemia can sometimes be seen after reperfusion, but this patient actually had a seizure. Based on the CTP findings, intravenous thrombolysis was withheld, even though the patient technically qualified by clinical criteria. Video EEG showed multiple seizure episodes over the next 24 hours, and there was no ischemia on the follow-up MRI. By now, it must seem like CT perfusion is a superhero. There's nothing this modality can't do. Can we just use it like the cardiologists use troponin to rule out a stroke in a patient with acute neurological deficits? Not quite. This patient presented with acute right sensory motor deficits. Stare at these image maps for a second. Do you see any abnormalities? I'm even giving you this patient's head CT as a clue. This patient has a left thalamocapsular lacunar infarction. Unfortunately, CT perfusion is terrible at identifying subcortical lacunar infarctions. I would argue that even the head CT picked up the stroke. Again, this is a stark reminder that even if CTP is completely normal, a patient may still have a stroke. Always examine the CTP in the context of clinical history and other imaging. We're at the end of our tour through CT perfusion. If you had the patience to sit through the entire talk, it's time for your well-deserved summary. If a patient with acute stroke symptoms presents within 6 hours from last known well, CT perfusion is not necessary for intervention. But it may be considered if time of onset is suspect, or if there's a concern for medium vessel occlusion or stroke mimic. If a patient presents beyond 6 hours from last known well, advanced imaging like CT perfusion is required to identify appropriate patients for intervention. Next, quickly assess the quality of study. I'm talking about verifying appropriate vessel selection, appropriate contrast opacification, and minimal movement. If the study is inadequate, consider performing an MRI. If the study is adequate, then look for a delay in flow on Tmax maps. If Tmax is normal, large or medium vessel occlusion is unlikely. Get a more detailed history and examination, consider stroke mimics, and take a look at the CBF-CBV source maps. Again, the gold standard imaging here is MRI. Over 6-second delay is used as a surrogate for penumbra. An area of over 6-second delay is concerning, and we should review the CTA for the presence of large vessel occlusion. If the intracranial vessel occlusion is absent, we need to explain delay in flow by evaluating the cervical carotid. Note that we're talking about delays in the anterior circulation. If cervical carotid occlusion is present, consider that penumbra is being overestimated in a patient with chronic carotid occlusion. But before you call off the intervention, you need to correlate with clinical examination, non-contrast head CT, and review the hypoperfusion ratio. Hypoperfusion ratio is the ratio between Tmax over 6 seconds and Tmax over 10 seconds thresholds. It may provide a clue that a substantial amount of tissue is at an immediate risk of ischemia, like in this example. If cervical carotid occlusion is absent, consider artifactual result, especially if the areas of flow delay are near the skull base or orbits. If proximal intracranial vessel occlusion is present, then assess ischemic core, area of cerebral blood flow less than 30%. Be very careful here, since core heavily influences candidacy for thrombectomy. We start by comparing the CBF map to the non-contrast head CT. To be able to trust CT perfusion's core estimation, obvious hypodensity on the head CT must be absent. Otherwise, you may be dealing with a rare situation where leptomeningeal collaterals were recruited late. Cerebral blood flow has improved, but brain tissue is already infarcted. So the core may be underestimated. Ischemic core over 70 cc's generally increases the risk of reperfusion hemorrhage and makes intervention unfavorable. But before we finalize that conclusion, we need to double-check that non-contrast head CT. If aspects is low and a significant hypodensity is present, both CTP and non-contrast head CT agree that a large stroke has already occurred. Intervention should be avoided. If aspects is high, there is no significant hypodensity. You may be dealing with a rare situation where a core is overestimated in the patient who presents very early from stroke onset, perhaps even within the golden hour. Consider using the more stringent CBF less than 20% threshold to better estimate core in this situation. If the ischemic core is at most 70 cc's, assess for penumbra core mismatch. If a mismatch is present, the patient may be a candidate for perfusion therapy. If the mismatch is at least 1.2 times or 10 cc's, TPA may be considered in a patient with a wake-up stroke within 9 hours from the midpoint of sleep. Extend trial criteria. If the mismatch is at least 1.8 times or 15 cc's, then mechanical thrombectomy may be considered per DEFUSE 3 criteria. And finally, if this process yields uncertain or confusing results, the ischemic core can always be evaluated more accurately with the gold standard diffusion-weighted imaging MRI. And that's all for today. As always, thank you for your kind attention. Until next time, bye.